My name is Mathoka Mutinga. I'm an associate physician in the Division of Gastroenterology, Hepatology, and Endoscopy in the Department of Medicine at Brigham and Women's Hospital, and an assistant professor of medicine at Harvard Medical School. The topic today that I'll be discussing is GI board review. I have no disclosures to report. The first case is a 78-year-old man who's referred for evaluation of dysphagia. He reports intermittent choking sensation, more so with liquids than with solids. His symptoms have been ongoing for several months. He's a smoker. He has not experienced frequent heartburn. And the question is, which of the following tests would you order first to evaluate his symptoms? A barium swallow X-ray. B, an upper endoscopy. C, a video swallow study. Or D, a high-resolution esophageal manometry. The answer is C, the video swallow study. This patient has typical symptoms that would suggest oropharyngeal dysphagia. He reports difficulty handling liquids and also a choking sensation, which would suggest a problem with the initial phase of swallowing. When we think about patients with swallowing disorders, the first question to ask is this a problem that involves the first portion of swallowing, the oropharyngeal phase, or the second phase of swallowing, the esophageal phase, when the bolus has already entered the esophagus? And some of the clues to the first problem, the oropharyngeal phase, would be symptoms such as coughing when you swallow, nasal regurgitation, difficulty initiating a swallow, and also abnormal phonation. These would suggest a problem with the oropharyngeal phase of swallowing. Whereas symptoms that occur after the bolus has been swallowed would suggest an esophageal problem. And then one must distinguish whether this is a mechanical problem or whether this is a motility problem. Mechanical problems tend to cause difficulty with swallowing solids. And then motility problems of the esophagus tend to cause difficulty swallowing liquids and solids. For an oropharyngeal problem, as this is suggested in this case, a video swallow study, also known as a modified video swallow, is the test of choice. For an esophageal problem, if a mechanical problem is suspected, then a barium swallow study or an upper esophageal endoscopy is recommended. And then for a motility disorder, a high-resolution manometry study is the test of choice. Question number 2. A 24-year-old man with a recent episode of esophageal food impaction, which resolves spontaneously, undergoes an upper endoscopy to evaluate these symptoms. On endoscopy, he is noted to have multiple linear furrows and small whitish plaques. Biopsies are obtained from the mid and distal esophagus and are notable for greater than 50 eosinophils per high power field, noted both in the specimens from the mid and the distal esophagus. Which of the following symptoms is atypical for eosinophilic esophagitis? A, heartburn. B, non-cardiac chest pain. C, esophageal dysphagia. Or D, nausea. So the answer is D, nausea. And in fact, symptoms such as nausea, vomiting, abdominal pain, weight loss, diarrhea, and gastrointestinal bleeding are atypical in patients with eosinophilic esophagitis and should lead one to think about alternate diagnoses such as eosinophilic gastroenteritis. The symptom of heartburn is actually quite common, reported in about 30 to 60% of adults. Non-cardiac chest pain is reported in about 8 to 44% of adults. Esophageal dysphagia is the most common symptom that is associated with eosinophilic esophagitis, and it's reported in about 60 to 100% of adults with this condition. The third question is a 41-year-old man recently diagnosed with acute sigmoid diverticulitis that was confirmed on CT scan imaging, is referred to a gastroenterologist for further management. He reports no prior problems with diarrhea or constipation. He has not experienced rectal bleeding. There's no family history of colorectal cancer or polyps. He smokes 1/2 pack of cigarettes per day. In addition to advising smoking cessation, what should be recommended next? A fiber supplement. B, avoidance of seeds and nuts. C, schedule a colonoscopy. Or D, a stool softener. The answer is C. We should recommend a colonoscopy. And the reason is that we want to exclude the possibility of an occult colonic neoplasm that could mimic diverticulitis. Smoking is associated with an increased risk of diverticulitis, and cessation should be recommended, as in this case, to reduce the risk of recurrence of diverticulitis, as well as for the many other health benefits associated with smoking cessation. Contrary to popular belief, consumption of seeds and nuts is not associated with an increased risk of diverticulitis. And although a high dietary fiber intake may be associated with a lower risk of diverticulitis, excluding an occult colonic malignancy is far more important. As far as the stool softener option, it's not indicated in the absence of constipation. The fourth question. A 57-year-old gentleman with a long history of gastroesophageal reflux undergoes an esophagogastroduodenoscopy, EGD, which reveals a 5-centimeter long segment of salmon-colored mucosa extending proximally from the gastroesophageal junction. Biopsies reveal Barrett's esophagus without dysplasia. 1 year later, he has a repeat upper endoscopy, and it reveals Barrett's esophagus with indefinite features for dysplasia. His acid suppressive therapy is subsequently intensified. And the question is, what is the proper subsequent surveillance protocol for this particular patient? Should we repeat an upper endoscopy in a month? Or B, repeat biopsies in 3 to 6 months? C, repeat biopsies in a year? D, repeat biopsies in 3 to 5 years? Or E, no further surveillance is necessary? So the answer is B. We should repeat an upper endoscopy in 3 to 6 months. So just as a reminder, Barrett's esophagus is intestinal metaplasia of the esophagus. It's associated with an increased risk of adenocarcinoma of the esophagus. If we find no dysplasia when doing surveillance biopsies for Barrett's esophagus, we should repeat an upper endoscopy in 3 to 5 years. If features that are indefinite for dysplasia, as in this case, are noted, we should intensify acid suppressive therapy, and it's recommended to repeat an upper endoscopy with biopsies in 3 to 6 months. If low-grade dysplasia is detected, it's important to have a second pathologist confirm this diagnosis, and if confirmed, we should refer that patient for ablative therapy, usually using radiofrequency ablation. And if the patient declines to have this, then a repeat upper endoscopy on an annual basis would be advised. Lastly, if high-grade dysplasia is found on a surveillance upper endoscopy, it's also important to have this reconfirmed with a second pathologist, and if confirmed, to do ablation therapy, and if any discrete lesions are noted, endoscopic mucosal resection should be performed. Question number 5. A 21-year-old student is referred for evaluation of rectal bleeding and intermittent loose stools associated with urgency. His weight is stable, and he reports no abdominal pain. Stool cultures are obtained and reveal no infection. The symptoms have been ongoing for a month, but he delayed seeking medical attention, thinking that the symptoms would probably resolve. Ultimately, a colonoscopy is performed, and it reveals inflammation that's just localized to the rectum. Biopsies reveal chronic active proctitis, that's rectal inflammation, and normal mucosa in all other regions of the colon. And the question is, which of the following is associated with a poor outcome in patients with ulcerative colitis? Is it A, pancolitis, B, older age, C, normal C-reactive protein level, D, current smoker, or E, normal hemoglobin? The answer is A, pancolitis. And patients with extensive or pancolitis have a higher risk of requiring a colectomy. Other poor prognostic factors include younger age. Patients with younger age are associated, tend to have more severe disease and tend to have a shorter time to relapse and increased risk of colectomy. Elevated CRP or elevated SED rate, inflammatory markers, are associated with a higher risk of colectomy. On the other hand, current smokers actually have a lower rate of relapse and have fewer hospitalizations, therefore tend to have a milder course. Other poor prognostic factors include a low hemoglobin level or low fibrinogen level, which are independently associated with treatment failure in patients with severe colitis. Patients who are non-smokers or ex-smokers also typically have more extensive disease and also have a lower likelihood of disease progression. Question number 6. A patient with hepatic cirrhosis due to alcohol abuse is found to have large esophageal varices on upper endoscopy, but has no history of prior gastrointestinal bleeding. The question related to this case is, what is the appropriate therapy to prevent future variceal bleeding? Should we A, perform a transjugular intrahepatic portosystemic shunt procedure or TIPS procedure? D, should we prescribe an oral nitrate? C, should we prescribe a non-selective beta blocker? D, should we do endoscopic sclerotherapy of these varices? Or E, should we prescribe a proton pump inhibitor? So the answer is C, a non-selective beta blocker. And indeed, patients with portal hypertension who have large varices benefit from pharmacologic prophylaxis with non-selective beta blockers. These medications can reduce the risk of an initial bleed by up to 40%. With regards to endoscopic sclerotherapy, when used for primary prophylaxis, it has been shown to be ineffective and possibly harmful. Variceal band ligation, which is not an option, has shown initial promise in patients with large varices and should be considered in patients who have contraindications for non-selective beta blocker therapy or who do not have adequate response with beta blocker therapy. Oral nitrate monotherapy for primary prophylaxis of esophageal variceal hemorrhage is associated with an increased mortality and therefore is also not recommended. Acid inhibition therapy has really no role to play for prophylaxis of variceal hemorrhage. And the TIPS procedure, while very effective in lowering portal pressure, when used for primary prophylaxis of variceal hemorrhage, offers no mortality benefit and may actually cause harm. Question number 7. A 58-year-old man with no history of alcoholism, chronic viral hepatitis, or obesity is seen by his primary care provider for evaluation of increased abdominal girth as well as scrotal and lower extremity edema. An abdominal ultrasound is performed, and it's notable for moderate ascites. He has patent hepatic and portal veins, and he has a normal appearing liver contour. Arrangements are made for a diagnostic paracentesis. The question is, ascites is classified by the serum ascites albumin gradient, known as SAG, which is obtained by subtracting the albumin level in the ascites from that in the serum. Which of the following conditions will cause ascites with a low SAG gradient? That is a gradient less than 1.1 milligrams per deciliter. Is it A, Budd-Chiari syndrome, B, cirrhosis due to chronic hepatitis C, peritoneal carcinomatosis, D, congestive heart failure, or E, acute alcoholic hepatitis? The answer is C, the peritoneal carcinomatosis. And before we discuss that, we'll mention that the serum ascites albumin gradient, or SAG, as we mentioned, it differentiates ascites due to portal hypertension, in which the SAG is greater than 1.1, from that due to non-portal hypertensive states, in which the SAG is less than 1.1, with about a 97% accuracy. So for causes of ascites with low SAG gradient, some of the conditions include peritoneal carcinomatosis, tuberculous peritonitis, and fungal infections of the peritoneum. All the other options that were given in this case would be associated with a SAG greater than 1.1. Question number 8. A 53-year-old man is diagnosed with celiac disease after undergoing evaluation of symptoms which included bloating and irregular bowel patterns. He has complete resolution of symptoms after adhering to a gluten-free diet for 2 months. Labs are obtained at a follow-up and are notable for thrombocytosis. Specifically, his platelet count is 634,000, with a normal range of 150,000 to 400,000. He's not anemic. His iron indices are all normal. His CRP is normal, and he has no signs of ongoing infection or inflammation. Additional evaluation is pursued and a diagnosis is made. The question is, which of the following interventions should be considered for further management of this patient? Should we do a bone marrow biopsy? Should we recommend a pneumococcal vaccination? Should we administer intravenous iron? Should we prescribe hydroxyurea? Should we schedule a phlebotomy? So the answer is B. That is, we should do a pneumococcal vaccination. This is a tough question, but just to review. So what this patient has is a complication of celiac disease known as either anatomic or functional hyposplenism. And this can be confirmed with imaging and also even with the evaluation of a peripheral blood smear looking for Powell-Jony bodies. And patients who have anatomic or functional hyposplenism are at increased risk from infections by encapsulated bacteria, such as pneumococcus, for example, and should receive appropriate vaccinations. Patients with celiac disease are at increased risk of small intestinal lymphoma, but for those who chose an option of bone marrow biopsy, thinking of this diagnosis, it's actually not helpful in making a diagnosis of small intestinal lymphoma. The intravenous iron administration option is not an acceptable choice because this patient does not have iron deficiency. And with regards to the option of hydroxyurea, although this patient has thrombocytosis, it'd be unlikely that you'd have a myeloproliferative disorder such as essential thrombocytosis. And in addition, his thrombocytosis is not severe. Regarding the option of phlebotomy, this is actually used to treat iron overload, not thrombocytosis. Question number 9. A 35-year-old woman is evaluated for fatigue. She has not experienced insomnia. She doesn't report excessive daytime somnolence or menorrhagia, and her body mass index is normal. She does not consume alcohol, and a depression screening questionnaire is negative. Her physical exam is unremarkable. Her lab tests are as follows. She has a TSH of 1.50, which is normal. She has a hematocrit of 42%, which is normal. Her liver biochemical tests are all normal. Her serum iron is 180. Her TIBC, the total iron binding capacity, is 230. Her serum ferritin is 195. Her transferrin saturation is 78%. The question is, what test would you order next to aid in her diagnosis? Should we recommend a percutaneous liver biopsy? Should we order a sleep study? Should we do glucose tolerance testing? Should we order an HFE gene test? Or perhaps should we order an echocardiogram? And the answer is D. We should order an HFE gene test. And the clue in this case is this elevated transferrin saturation that is over 55%. This would suggest an iron overload syndrome. And hemochromatosis, genetic hemochromatosis, is one of the most common types of our causes of iron overload. And therefore, an HFE gene test to evaluate for the two most common gene mutations, C282Y and the H63B, should be ordered. Now, you might be surprised that the ferritin level is normal, and indeed it can be normal in menstruating women. For those who thought about the option of doing testing for diabetes, remember that diabetes is a late manifestation or complication, I should say, of iron overload and hemochromatosis to be specific. And it would be unlikely to occur in someone who has no evidence of hepatic injury. And those who may have selected the echocardiogram, thinking about complications of hemochromatosis, such as dilated cardiomyopathy, this too is a late complication of hemochromatosis. She has no evidence of even hepatic injury, so it would be unlikely. Some of the early complications, cardiac complications of hemochromatosis, though, could include atrial arrhythmia. So we see an atrial arrhythmia in a young person, always think about the possibility of hemochromatosis. So just keep that in mind. Question number 10 is a 42-year-old with a prior history of hypertension, severe sleep apnea, and morbid obesity who underwent a Roux-en-Y gastric bypass operation 4 years ago. He's referred for evaluation of symptoms that include excessive intestinal gas, bloating, and loose stools, which have been ongoing for several months. He doesn't consume dairy products, carbonated beverages, or artificial sweeteners. He hasn't taken any antibiotics, and there have been no major changes in his medication. His weight has also been stable. Labs for celiac disease are normal, as is the CBC with differential, the albumin level, TSH, CRP, fecal calprotectin, and even stool tests for C. difficile, bacterial pathogens, and parasites such as Giardia and Cryptosporidium. The question is, what would you recommend next to establish this diagnosis? Should we schedule a colonoscopy with biopsies? Should we order an MRE, a magnetic resonance enterography? Should we obtain an abdominal ultrasound? Should we order a breath test for small intestinal bacterial overgrowth? Or B, should we do a gastric emptying test? So the answer is D. We should order a breath test to look for small intestinal bacterial overgrowth, realizing that this condition is actually quite common in those who undergo a Roux-en-Y gastric bypass operation. A colonoscopy and MR enterography, though tempting to obtain because he has loose stool, would be likely low yield because his CRP is normal and fecal calprotectin tests are normal. Thus, intestinal inflammation is unlikely. For those who might think that perhaps his symptoms could be related to a gallstone complication, gallstones develop in about 25% of patients who have undergone gastric bypass surgery, but he has no symptoms to suggest biliary colic, and so this is likely to be of low yield. And lastly, for those who might have thought about the possibility of a gastric emptying problem, realize that number one, his symptoms are typical of gastroparesis, and secondly, patients who have undergone a Roux-en-Y gastric bypass actually tend to have enhanced gastric emptying. Question number 11. A 32-year-old woman presents to a travel clinic requesting advice about protecting herself from hepatitis E infection. She's planning to travel to an endemic area for 1 week. She has no significant medical history, and she does not take any medication. And the question related to this case is, which of the following statements regarding hepatitis E is true? A, the virus is endemic in Southeast Asia. B, the clinical features of hepatitis E are similar to those of hepatitis B. C, the virus is transmitted primarily via percutaneous blood exposure. D, it is associated with a high rate of fulminant hepatic failure in most patients. E, a vaccination is readily available in the United States. And the answer is A. Hepatitis E is endemic in a number of areas, including Southeast Asia, Africa, the Middle East, and Central America. This virus is transmitted via a fecal-oral route, similar to hepatitis A. Therefore, good sanitation and the use of boiled water and boiled and chlorinated water reduces the risk of infection. People should also avoid raw vegetables, raw fruits when traveling to these areas where it is endemic. Like hepatitis A, it is generally associated with a self-limited icteric illness. However, in pregnant women, there's a high rate of fulminant hepatic failure, up to 25%. In the United States, there is no FDA-approved hepatitis E vaccine. However, a recombinant vaccine was approved for use in China in 2012. Question number 12. A 62-year-old man with recently diagnosed compensated cirrhosis due to non-alcoholic steatohepatitis is advised to discontinue statin therapy by his primary care provider due to concerns about possible hepatotoxicity. He's obese, has hypertension and dyslipidemia, but does not have diabetes mellitus or coronary heart disease. The question is, which of the following is believed to be true concerning the effects of statin therapy in patients with chronic liver disease? A, statins may decrease overall survival. B, statins may increase the risk of hepatic decompensation. C, statins may decrease the risk of developing hepatocellular carcinoma. Or D, statins may retard the progression and or development of cirrhosis. The answer is D. Statins appear to retard the progression and or the development of cirrhosis, likely by inhibiting pro-fibrotic cytokines. And in fact, recent data shows no evidence that statins are deleterious in patients with chronic liver disease, including those with compensated cirrhosis. Some of the additional benefits of statins is that they appear to improve the overall survival in patients with chronic liver disease and decrease the risk of developing hepatic decompensation. Statins are not known to have any direct effect on the development of hepatocellular carcinoma. Question 13. A 64-year-old woman with COPD presents for evaluation of recurrent diarrhea and mild diffuse abdominal pain. 3 months ago, she was treated with oral metronidazole for 10 days for a C. difficile infection following antibiotics to treat acute bronchitis. A confirmed recurrence of the C. diff infection occurred 6 weeks later. She was treated with oral vancomycin for 10 days. She now presents with watery diarrhea for the past 2 days. She has not received any antibiotics in the interim, and stool testing is again positive for C. diff toxin. Her labs are normal except for a white blood count of 16,000. She's afebrile, normotensive, and she's not tachycardic. She's unwilling to consider a fecal microbiota transplantation after treatment of the current C. diff infection. Which of the following would be the most appropriate treatment for this second recurrence of C. difficile infection? A, oral vancomycin for 14 days. B, rifaximin for 14 days. C, fidaxomicin for 10 days. Or D, metronidazole for 14 days. The answer is C. So with a second recurrence of C. difficile infection, The recommended treatment is either fidaxomicin 200 milligrams by mouth twice per day for 10 days, or pulsed and or tapering dose of oral vancomycin. This was not an option in the questions. Fidaxomicin has the advantage of being associated with a lower risk of recurrence of C. difficile infection compared to currently available antimicrobial agents. However, it is very expensive. So in addition to treating her with fidaxomicin, if she were willing, which in this case she was not, patients should be considered for fecal microbiota transplantation. The other options that were given, the oral metronidazole, oral vancomycin, and rifaximin are not recommended for a second recurrence, but the oral metronidazole and oral vancomycin are preferred treatment for an initial episode of C. difficile infection and for the first recurrence if a patient has a mild to moderate disease. Question number 14. A screen colonoscopy on a 50-year-old man with no history of colon cancer reveals two small flat polyps in the ascending colon, which are resected. The pathology reports that they are sessile serrated adenomas. And the question is, which statement regarding serrated adenomas is true? A, they're not associated with an increased risk of metachronous colon cancer. B, the prevalence of serrated polyps is very low. C, they disproportionately contribute to interval colon cancers. Or D, they're easily detected on colonoscopic examination. The answer is C. Serrated polyps are associated with an increase of metachronous cancer and certain types of other synchronized lesions, and they disproportionately contribute to interval colon cancer. What are serrated polyps? These are polyps which histologically resemble hyperplastic polyps. They have these serrated or sawtooth appearance of the cryptoepithelium. And unfortunately, they're easily missed on colonoscopy because they tend to be flat, they tend to have an ambiguous color, and they tend to be in the proximal colon, which often is not as well cleansed as the distal colon. That is one of the reasons that a split dose bowel preparation is favored, because it helps to improve the quality of the bowel preparation, especially in the proximal colon where these polyps can be found. Serrated polyps are actually quite common, with an estimated prevalence of anywhere from about 5.6% to 28.7% in one meta-analysis, as noted. And as I mentioned earlier, in addition to the serrated polyps disproportionately contributing to interval colon cancer, they're also associated with an increased risk of metachronous cancer, and certain types are also associated with an increased risk of synchronized advanced neoplasia. Question number 15. A 35-year-old with mild Crohn's disease presents with symptoms of severe epigastric pain. He doesn't drink alcohol. His only medication is oral mesalamine. And lab tests are notable for a lipase of 2,500, a total bilirubin of 2.5, direct bilirubin of 0.5, AST of 17, ALT 25, alkaline phosphatase 72, serum creatinine 0.7, and hematocrit is 38% after hydration. He does not meet any systemic inflammatory response syndrome SIRS criteria. And the question is, which of the following imaging tests would be most appropriate at this time? Should we do an ERCP? Should we do an abdominal ultrasound, an MRCP, or KUB? The answer is B, an ultrasound. We should perform an ultrasound. Recognizing that patients with Crohn's disease are at increased risk of developing gallstones, and since he has no obvious cause for pancreatitis, it's important to exclude gallstones. It's reasonable to think about medications causing pancreatitis. Mesalamine can very rarely cause pancreatitis. A more common medication would be something like 6-mercaptopurine or azathioprine. As far as the ERCP, which is actually an endoscopic procedure, it's only recommended in the setting of pancreatitis if a patient has evidence of ascending cholangitis or severe or high-grade biliary obstruction. In this particular case, the elevated bilirubin, as you will note, is indirect, is predominantly indirect hyperbilirubinemia, which would suggest Gilbert's syndrome rather than an obstructive biliary process, hence an MRCP is not indicated. And similarly, no real reason to do a KUB. We don't really suspect another complication such as bowel perforation causing this upper abdominal pain. Question number 16, a 42-year-old man is found to have occult blood in the stool on routine digital rectal exam during a physical exam. He has no upper or lower gastrointestinal symptoms and does not take aspirin or NSAIDs. There's no family history of gastrointestinal malignancy and his hematocrit is normal. Which of the following could potentially cause occult gastrointestinal blood loss? A, Meckel's diverticulum, B, Barrett's esophagus, C, colonic diverticulosis, or D, Cameron lesions? The answer is D, Cameron lesions. What are Cameron lesions? They are ulcers or erosions at the lower margin of large hiatal hernias. They can cause both acute as well as chronic blood loss and even iron deficiency anemia. A Meckel's diverticulum is a congenital vestigial remnant of the omphalomesenteric duct. It's usually located within 2 feet of the terminal ileum, and 2 feet of the ileocecal valve, pardon me. And most are asymptomatic. Occasionally, they can contain ectopic gastric mucosa, which can ulcerate and cause overt bleeding rather than occult blood loss. Similarly, colonic diverticuli can cause overt gastrointestinal hemorrhage, but not occult blood loss. And lastly, Barrett's esophagus is a non-inflammatory lesion. It is characterized, as we mentioned earlier, by intestinal metaplasia of the esophagus, and therefore it would not be associated with occult blood loss. Question 17. A 42-year-old woman with hypertension, type 2 diabetes, dyslipidemia, and obesity is noted to have multiple small gallstones and a fatty liver on ultrasound that was performed to evaluate transaminase elevation, mild transaminase elevation. The common bile duct measures 3 millimeters. There's no intrahepatic ductal dilation. She reports no episodes of pain that would suggest biliary colic. But she's quite anxious, and she worries about the developing complications of gallstones, especially since she has diabetes. Lab tests to rule out other causes of transaminase elevation are normal. And the question is, what would you recommend for this patient? Should we send her for elective cholecystectomy since she's diabetic? Should we prescribe ursodeoxycholic acid? Should we recommend lithotripsy? Or D, should we just do no intervention? And the answer is D. What this patient has is asymptomatic cholelithiasis. She's been incidentally noted to have gallstones. She reports no symptoms that would suggest biliary colic. And these patients do well over long periods of time. Only about 20% develop symptoms over a 15-year follow-up. And in most cases, it's biliary colic. And therefore, the risk of cholecystectomy outweighs the benefits, even in diabetic patients. And we should therefore not recommend surgery in these patients. Question 18, a 44-year-old man with poorly controlled type 2 diabetes, mellitus, and morbid obesity presents to the emergency department for evaluation of severe acute epigastric pain radiating to his back for the last 3 hours. He's afebrile, his heart rate is 92, blood pressure 154/90, he has no orthostasis, his respiratory rate is 24, his oxygen saturation is 98% on air, he has hypoactive bowel sounds on exam, and he has moderate epigastric tenderness with light palpation. His sclera are anecteric. On digital rectal exam, he has no occult blood, and he has no peripheral edema. His labs are notable for a white count that's elevated to 14,000, hematocrit of 43. His ALT and AST are both mildly elevated. Alkaline phosphatase and bilirubin are normal. His sodium is low, 126. His glucose is 215. His BUN is 12. Creatinine is 0.85. Amylase is normal, 55, but his lipase is markedly elevated, 4,589. An ultrasound is performed and it is notable for increased echogenicity of the liver, suggestive of fatty liver. It has normal appearing gallbladder. There are no gallstones. It's common bowel duct of normal diameter. There's no intrahepatic ductal dilation. And an abdominal pelvic CT scan is also performed and notable for interstitial pancreatitis with peripancreatic fat stranding, but no necrosis. He also does not consume alcohol. And the question is, what is the likely cause of this acute pancreatitis based on the data that's been presented? A, is it gallstones? B, could it be a pancreatic mucinous neoplasm? C, hypertriglyceridemia? Or D, sphincter of OD dysfunction? The answer is C, hypertriglyceridemia. And the clue to this case are two things. One is the hyponatremia, and secondly, the hyponatremia is the first one. And the second thing is the normal amylase level, but marked elevation of the lipase. And we'll go through that discussion in a minute. Just to let you know, hypertriglyceridemia is an important cause of a risk factor for acute pancreatitis, especially if the triglyceride level exceeds 1,000. And indeed, hypertriglyceridemia-induced acute pancreatitis is the third most common cause of acute pancreatitis after alcohol and gallstones. Now, the excess triglyceride causes pseudo hyponatremia. It's actually factitious. And so that's one clue that there's something, some other cause for his pancreatitis. The second thing is that the elevated triglycerides, especially if they're over 500, they interfere with the colorimetric test that's used to determine the amylase level. And if one were to dilute the serum, one could get the accurate reading of the amylase level. His lipase is markedly elevated, so it's a little unusual, very unusual that amylase is normal. So what are some of the secondary causes of hypertriglyceridemia? These include poorly controlled diabetes, certain medications such as steroids, pregnancy, alcohol, hypothyroidism. Certainly you could have a primary cause, one of these dyslipidemias. Question number 19, a 23-year-old returning foreign traveler is seen in urgent care with complaints of unilateral knee pain and swelling. She reports no trauma and is not sexually active. She had a self-limited diarrheal illness during her trip. She's well appearing and lab tests are normal. Which of the following statements regarding reactive arthritis following an enteric infection is true? A, intestinal infection with amoeba has been associated with this syndrome. B, many affected people are HLA-DQ2 and DQ8 antigen positive. C, there's a high female to male ratio. Or D, it may be associated with a triad of arthritis, conjunctivitis, and urethritis. The answer is D. It can be associated, it's often associated with a triad of arthritis, conjunctivitis, and urethritis. So what post-enteric reactive arthritis, which was formerly known as Reiter syndrome, it typically develops about 2 to 4 weeks after an acute diarrheal illness. The most common pathogen associated with this is Shigella species, but it can be associated with other enteric organisms, including Salmonella, Campylobacter jejuni, Yersinia enterocolitica, and even C. diff, but it's not been reported to occur with amoeba. It's more common in men than in women, and many affected patients are HLA-B27 antigen positive, not HLA-DQ2, DQ8, which is seen more commonly with celiac disease. Question number 20. A 36-year-old woman is seen in the office for evaluation of a sensation of a lump in her throat that's been ongoing for several months. She reports no dysphagia or dynaphagia, and her head and neck exam is unremarkable. Which of the following is a common cause of a globus sensation? A, parathyroid adenoma. B, gastroesophageal reflux disease. C, depression. Or D, myasthenia gravis. And the answer is B, gastroesophageal reflux. So globus refers to a sensation of a lump or foreign body in the throat in the absence of dysphagia and odynophagia. One of the most common causes is gastroesophageal reflux. In addition, anxiety, but not depression, goiters, and sometimes even early hypopharyngeal cancers can cause a globus sensation. Myasthenia gravis can cause oropharyngeal dysphagia by affecting some of the muscles in the pharynx, but does not cause a globus sensation. And parathyroid adenomas are generally very small and are unlikely to cause a globus sensation. Question number 21. A 57-year-old African-American man with chronic dyspepsia is referred for an open access esophagogastroduodenoscopy EGD. He reports no aspirin or NSAID use, and he also has not experienced frequent heartburn or dysphagia. His weight is stable. He doesn't take any medications, and a previous short-term trial of a histamine blocker resulted in temporary reduction of symptoms, but with subsequent recurrence. He has never traveled outside the country. His upper endoscopy is notable for diffuse moderate gastric erythema, but no ulcers or mass lesions are seen. The esophagus and duodenum are normal appearance. Gastric biopsies are obtained both from the antrum and the body and are notable for chronic active gastritis associated with Helicobacter pylori bacterial infection. Limited gastric intestinal metaplasia is also noted. There's no family history of gastric cancer, and he is a non-smoker. And the question is, which intervention would be most effective in reducing this patient's long-term risk of developing gastric cancer? A, should we do surveillance upper endoscopies every 3 to 5 years? B, surveillance upper endoscopies on an annual basis? C, prescribe acid suppressive therapy? D, prescribe H. pylori eradication therapy. The answer is D. H. pylori infection and associated chronic gastric inflammation is a risk factor for development of gastric adenocarcinoma. Therefore, treatment of H. pylori infection and confirmation of eradication is strongly indicated. There are several additional factors that are associated with an increased risk of incident gastric cancer, which may warrant consideration of surveillance upper endoscopies every 3 to 5 years in patients with gastric intestinal metaplasia, as in this particular case. And that is number one, if the patient also is a smoker, if the patient has a family history of gastric cancer, or if the patient has extensive intestinal metaplasia and incomplete histologic subtype. Thank you again for your attention, and again, I have no disclosures to report.